welcome you all to OrthoTV OrthoXpert Series. And I take great pleasure in inviting today's speaker. He is Professor Dr. SWAPNIL Kenny. He is the National Delegate of SICOT India, a proud moment for all of us. He is a pediatric orthopedic surgeon practicing in Mumbai, attached to Zen Hospital, Sir H.N. Reliance Foundation Hospital and Apollo Hospital, Seawood, Bilapur. And he's going to talk on very interesting topic today, minimally invasive surgery, MIS in pediatric orthopedic trauma, a technology-driven care. So with this, I hand over to Dr. SWAPNIL Kenny to take the proceedings forward.
Thank you very much, Dr. Neeraj, Bijlani and OrthoTV for this opportunity. I shall be speaking on a very interesting topic, what is probably relevant to the young generation and the next generation. It is essentially minimally invasive surgery in pediatric orthopedic trauma. Now, when I was a resident almost 25 years ago, either most of these cases of trauma in children would be conserved or they would be treated by open surgeries or limited surgeries, but mostly they would basically be treated in a cast. Now, all that has changed over the last 25 years. However, there is one truth which remains and which is relevant even today. And the truth is that most of the damage in orthopedic trauma is done in trying to reach a pathological bone by cutting open normal soft tissues. Hence, if you are performing a surgery, especially in children, when the indication is reasonable, you cannot get away with a subtotal bony fixation because it will have a cumulatively negative effect on the final outcome. Now, before we actually dwell into MIS, let's try and see the history of minimally invasive or keyhole surgeries. The first laparotomy was done in the 1800s, and it took us more than 130 years from moving to an open surgery to a scopic surgery. But it again took us about 60 to 70 years to get into robotics. And today, the situation is such that we have moved from robotic surgery to automated surgery, and eventually we will do a surgery sitting in our living rooms using a console. Right? So if you look at the history of keyhole surgeries, today we are doing intrauterine surgeries, the pediatric surgeons, where they are actually intervening a congenital anomaly or a congenital defect in a child going through the uterus of the mother and doing the surgery, closing the uterus again, and waiting for the child to be delivered. That's what we are looking at. So if you look at the history of image-guided surgery or even machine-guided surgery, we have come a long way. And specifically in leaps and bounds over the last 8 to 10 years. Now, what does the future hold? The predicted trajectory per se is that we have moved from freehand open surgery to minimally invasive surgery, now to robotic assisted surgery, and eventually a full automation, which I mentioned, wherein we will just be sitting in our living rooms and in our offices on consoles and performing these surgeries. Everything will be automated right from the time the patient is shifted in to the time the patient is moved out. So what essentially has changed? What is the difference between now and 10 years back? So there is a lot of difference. And a lot of it has to do with our curiosity. We have tried to understand newer things, newer concepts, tried to redefine our concepts of orthopedics in general and pediatric orthopedics in particular. We've had the connectivity thanks to media, social media, the World Wide Web, and fast internet speeds. Now, all this eventually what it has done is it has ensured that we get more and more creative. We're getting more and more creative. We're getting less and less invasive. And eventually, the end idea is that we need to give the best results to the patient, which then becomes the standard of care. And trust me, MIS in pediatric orthopedics is a game changer. It's a complete game changer. And why do I say that? Why is it a game changer? The reason is very simple. Now, let's look at this fracture. So when this used to come in 1999-2000, when I was doing my residency at the St. G.S. Medical College in KM Hospital, the treatment of this fracture when displaced was an open reduction through a triceps split approach. What we use for adults, the same thing was followed, where we opened up from behind, either split the triceps or went from the sides, both sides, the medial and the lateral side, isolated the ulnar nerve, and then open reduced this and fixed it with wires and came. Eventually, that open reduction started to be done from the lateral approach, but the posterior approach was too invasive, and it was to cause a lot of stiffness. So, believe me, in the last 10 years of clinical practice, except for vascular injuries, at times compound injuries, and injuries with neurological issues, most of my cases of supracondylar humerus fractures completely displaced, including irreducible fractures, have been managed purely with MIS without doing an open surgery. Like this patient today is my patient. I know this is irreducible, you cannot reduce it, but there are certain maneuvers you can do them. These are safe maneuvers where you can actually joystick the fragments, get a temporary reduction by joysticking them. Once you get a temporary reduction, you fix it, get a better reduction with multiple wires and fix it correctly. Now let's look at some metaphyseal fractures. This is a classic supracondylar humerus fracture, extension type. So you need to reduce the inflection. So the maneuver is basically traction, correction of varus valgus, a flexion of the distal fragment to get it into alignment with the proximal fragment. Once you do that, you either keep the arm supinated or pronated depending upon the fracture configuration and check for the kind of reduction you get. Once that is done, you start putting the wires inside and then you are done. Now, that was a reducible fracture. What happens if it is an irreducible fracture? For example, this particular fracture here was an irreducible fracture. It was there was a very small puncture wound which was there. So we were actually able to manipulate the distal fragment. If you see here, the distal fragment is really small, but we were able to manipulate it with the help of a hemostat, get it into position, and then fix it with multiple lateral K-wires. You can see a beautiful result over there. Now, not only for elbow fractures, but even for fractures of the radial head. Now, as we all know, there is something called as the PEDIATRIC technique, by which you can actually reduce a completely toppled radial head or radial neck fracture, put an elastic nail from down, get the fracture in position, and then once your fracture is in position and put the nail across the proximal fragment, just rotate the nail the other way around like I'm doing here, and the fracture is completely locked. So this is a stable method for doing a proximal radius fracture. Another patient, a completely toppled proximal radius fracture, the fracture of the ulna, everything done percutaneously without opening up. Ulnar fracture fixed with 2 K-wires. You don't really require a TBW in these cases. And the radius fracture reduced and fixed with the Physeal technique. Now let's look at one more challenging case. This is a distal end radius ulna, completely displaced fracture. Now, there was a time when these fractures used to be treated by closed reduction, put them in a plaster, accept some degree of overriding, some degree of bayonet reductions, some degree of angulation, some degree of rotations, and convince the parents that eventually this child will do well. Well, in today's day and age, things have really changed. Now, these kind of fractures, the parents and the patients are extremely demanding. Not do they want, not is it that they want a complete anatomical alignment, but they also do not accept a temporary deformity. We are, in fact, now reaching a stage where there is a very low threshold for patients and their parents to accept even a temporary deformity, which do remodel over a period of time. So then, can we perform these surgeries without being invasive? We definitely can. And how do we do it? So this is again 9.5-year-old child with a completely displaced radius fracture with an angulated femur fracture. So it's a very easy technique which I have described. This is how we do it. First get the distal fragment, then go to the proximal fragment. Once you reach the proximal fragment, you reduce the proximal fragment over the distal fragment. So this is a technique which I have described. That's a very, very simple technique, a very easy technique today. Even my residents do this technique very, very easily. And once you get this sort of a reduction, what you do is put a transfocal pin. It means that this pin actually goes across the fracture site and it fixes the fracture. Now, this is a temporary pin. And then you do add a couple of more metaphyseal pins going from the distal fragment into the proximal fragment, maybe 3 or 4 more pins, and put this patient in rest. So it's a very simple maneuver which I do when you slide the pin into the distal fragment. First, you hit the distal cortex of the distal fragment. You move your pin proximally and try and capture the distal cortex of the proximal fragment. You pass your wire inside the null of the proximal fragment. You lever the proximal fragment over the distal fragment and eventually you fix. So this is the way we fix these fractures. This is another patient, another case, a completely displaced radius ulnar distal radius ulnar fracture. It is a very unstable kind of an injury. And of course, you can do an attempt at loose reduction, but you will not get one. You will get a bayonet reduction, which is okay. But if you want a better reduction, if there is demanding parents, demanding children, juvenile athletes, or children who are participating in arts and sports, in that case, you actually need to be a little more proactive in reducing them anatomically and fixing them in a stable position before putting them in the cast. Once these heal, and they really heal very, very fast, once that happens, then you can remove the cast and start their rehabilitation. Now, what about diaphyseal fractures? In today's day and age, we have been able to treat most of the diaphyseal fractures in children with minimally invasive surgery. Now, I do not recommend fixation for humerus fractures in children. Most of them can be managed conservatively. However, there are certain situations where you require to do the nailing fixation. This was one such case where there was a compound wound which required debridement and, of course, fixation. I had the option of putting a fixator, but at the end of the day, other than an internal compound wound, there was nothing much, there was no contamination. So I was able to debride this wound, clean the bone from within, put the patient on IV antibiotics, and actually do a closed nailing from top. Once you do that, you can actually keep your wound open and press it. And believe me, children, it heals up very fast. If you can see this X-ray, this is at about 3 months. It has gummed up completely and it has completely healed. Now, once this healing has happened, then you can decide to remove this impedance. So what do you have? You have that small puncture wound which is there. You have a 3 to 4 centimeter wound at the top. So nobody can ever say that the patient has undergone surgery. Not only that, there is hardly any soft tissue dissection, hardly any trauma to the surrounding periosteum, and these are almost near biological fixations. Similarly, for femur fractures, now these are challenging to us. Usually, femur fractures below the age of 5 years are conserved. You have certain unstable situations like this particular case. which is actually a low subtrochanteric fracture. So a fracture of the femur in the subtrochanteric region. Now, this is really an unstable situation. We need to stabilize this. So what we tend to do is we tend to put it on a fracture table and do a retrograde kneeling from below. Because just two small incisions. What you need to remember very, very clearly and carefully is that you have to follow the principles of elastic kneeling. And what are the principles of elastic kneeling? The principles of elastic kneeling are two nails of equal diameter bent in a C-shaped fashion when are passed from the metaphysis from diametrically opposite points across the cortex. They get a complete cortical contact provided the spindle which is formed between the two C's is at the level of the fracture site with a good distal metaphyseal fixation gives you a 6-point fixation. So that is what elastic kneeling principle is. You have to follow the principle of putting only two nails. You cannot stack nails. If you stack nails inside this canal, then the principles of elastic nailing are completely voided, or they do not hold together. If they do not hold together, the fracture will not be stable, right? So if you are putting elastic nails, please and please always remember that you need to make the spindle at the fracture site or as close to the fracture site as possible if it cannot be at the fracture site. Now let's look at this case. This is a distal femur fracture. Again, a challenge. Unlike an adult, you don't need to plate it. So what you do is you again follow the principles of elastic nailing, wherein again from the spindle at the fracture site, try and get a near anatomical or at least an alignment reduction without opening the fracture fragments. Now, once you do that, you usually get a length stable fracture, which is rotationally unstable. So then to maintain the rotation, you can put a jest fixator, what is called as the Joshi's external stabilization system, and control the rotation completely. And that is complete healing of the fracture, and that is the patient's function. For upper tibia fractures, the options are limited, but in displaced fractures, you can use external fixators judiciously. In this particular case, I had used a pediatric LRS or a limb reconstruction system as my final form of fixation rather than trying to put a nail, because these are proximal fractures and usually getting a reduction in them, maintaining reduction in them, maintaining rotational alignment with them is a difficult task. Now let's look at some other injuries. This is a distal tibia fracture gone into valgus. And you would definitely ask me, why not a closed reduction? I do agree with you, but many a times these fractures tend to displace in valgus because the fibula is not completely fractured. It's a green stick fibula, which takes the tibia along with it and then gets into a valgus malalignment. So here, actually put elastic nails in the tibia, and you need to neutralize the forces which the tibia has from the fibula. So essentially, again, if you look at this X-ray, I am not really following the elastic principles. But if you look at the spindle, the center of the spindle is in the medullary canal. Two nails are very well fitting. And most important is that there is a good distal metaphyseal fit. So this fracture is stable because of the proximal forces of the spindle, which is keeping the proximal fragment in position, and a good metaphyseal fit in the distal fragment of two nails, which are inserted from diametrically equal opposite points, which are equal in diameter, but the two ends, the distal ends of the nails, are going in a divergent fashion and that is what is leading the reduction. And you can see there is no valgus at the fracture site eventually. You can also use it for pathological fractures. Like this was a fracture through a cyst. And whenever there is a pathological fracture, and if you tend to put an intramedullary implant across a pathological fracture, many a times the cyst heals naturally. So what this nail actually does is that it actually irritates the lining of the cyst, the simple bone cyst or a unicameral bone cyst as it is called. So it actually irritates the lining of the cyst wall, causing early healing and new bone formation, which is very, very clearly seen in the X-ray. Now, what about tibial shaft fractures, lower diaphyseal, completely displaced fractures? Again, trying to use the principle of elastic kneeling. If you see the X-ray there, my spindle is crossing the fracture site. Now, obviously, in this case, I cannot have the center of my spindle crossing the fracture site, but a part of my spindle is in the fracture site. The fracture is healed, and you can see complete range of motion and complete restoration of function, length, and rotation. You can also use this for compound injuries, where again I have not used the principles of elastic nailing, but I have stabilized the fracture with something called as internal splinting. So these nails put in this particular fashion are also called as internal splints, which hold the bone together. And then I have put a chest fixator top to control the rotation, and that is how it finally heals. Now, a very important question which you may have in your mind and which you may ask me is that why am I using a chest fixator and not, say, a 3.5 fixator or a mini fixator? The reason is very simple. These are already stabilized fractures. The only thing you require is rotation. One. Secondly, you don't want to cut any major holes or drill across this fracture site. You just need to put small K wires there. And what happens is once the wires are out, usually the holes which are there because of these wires, they tend to fill up. Because you're not actually damaging the bone by doing the thermal drilling. This is a low intensity exercise of putting the wires because it doesn't cut across, it doesn't make a channel across the bone, it just makes a small thin tunnel which eventually heals up very fast. So if you see a distal and radius fracture which you pinned, or if you see any other fracture you've pinned, and if you call the patient after 6 months, you will not be able to see the tracks of the K-wires because most of these tracks tend to heal up and fill up eventually with new bone formation. So that is where we are as regards healing of this particular fracture. Now let's try and look at certain physeal injuries. Now physeal injuries are completely different ballgame because here you require to have an anatomical reduction. If you do not have anatomical reduction, 2 or 3 things will happen. One is that you get a physeal malalignment in the physeal bar. Second is that you will get a step at the articular surface, which can cause arthritis. And third is that you can get severe stiffness and loss of range of motion. And that is why it is so important that for physeal injuries, you need to get a complete anatomical reduction. Let's look at this case. This is a patient who came to us with an injury to the elbow with a significant amount of swelling around the elbow. If you see the soft tissue swelling is significant, but that doesn't seem to be a fracture. There was a query fracture of the lateral condyle. So how do you confirm it? You confirm it minimally invasively by putting a dye across the joint, and this is called as an arthrogram. If you see the dye flowing, it first flows across the fracture site in the intra-articular region, and then it will line up the joint cavity. So now when I put this dye, it just shows me that there was a intra-articular fracture at the radial head, the lateral condyle is fractured, and this requires something. So if you do a CT, then you can see very clearly that there is a complete fracture. It's not a complete fracture. And this requires an in situ pinning because these can displace over a period of time. Now let's look at this next fracture. It is again a lateral condyle fracture. Anterior-posterior view looks good for issues. If you look at the lateral view, there is an opening of a hinge there posteriorly. Now that hinge here is what actually is the problem, because that is an unstable situation and this needs to be fixed. So you actually do an arthrogram, you see the entire lateral condyle because a large part of this lateral condyle is cartilaginous, and then you anatomically reduce it. Again, to reduce it anatomically, you require to see an arthrogram in the OT on the Shyam using a water-soluble dye so that you're 100% certain that you have reduced this fracture completely so that it can be fixed. So this is another case. Now this is a completely displaced fracture with the anterior hinge is lost. And here you can do an open reduction, but if you can get a close reduction, I'm getting a finger close reduction. So I have done that. That is the anterior hinge. That is the metaphyseal peak, which is intact. And this is a particularly large metaphyseal fragment. So we decided to put a screw, and that is where we are. That is the reduction. Our first wire goes across and holds the fracture. When you're putting a screw, you require one more wire going through the fragment, hold the fragment in position. You cannot put it on a single fragment because there will be rotation. Use a washer at times and get a complete compression like that, and that you cannot see the fracture line. So I left the wire inside for additional stability. I removed it for about 6 weeks once I removed the cast, and that was my final Shyam image, and that is my final fixation. Now, this is another case which presented to me quite late. It's almost about 3 weeks. As you can see, this is a completely angulated and to a certain extent displaced lateral condyle fracture. Now, this again requires anatomical reduction. You can either open it and do it, or you can use the advanced principles. And I was very lucky to get a very good reduction with the help of my finger. Once I was sure that I'm getting a reduction, I put a guide wire across the fracture from posterior to anterior, got a good hold of the cartilaginous fragment. And once I did that, I held this while drilling with the help of kind of a reduction forceps. And once that was done, I put my scope across it, and that gave me a good amount of compression. Now, this is almost very good near anatomical reduction. And many times you keep seeing this fracture line, but you don't have to worry about it. It is just probably a profile view in which you can see it. So don't really worry about these because they didn't heal well. This patient actually ended up doing very well. So that is the final result. If you can see, the fracture line is completely disappeared. Screw is within, got the screw out, and that was the complete final range of motion which this patient had. Now, similarly, you can also use it for distal femur fractures. Like this particular patient had completely displaced distal femur fracture. Now, this was reduced closed. So we were able to get a close reduction and some amount of extension. And I was able to put one metaphyseal screw and 2 smooth pins in a single insertion. So I was able to put a single insertion, 2 pins across this fracture site and get an anatomical reduction. Of course, later on, there was some sort of a physeal, it was not a physeal injury, but there was valgus. So probably there was a delayed growth on the medial side with, on the lateral side with the medial side going faster. So this patient had some amount of genu-valgum after all the healing. So we removed that screw there. Many a times this genu-valgum is not because of your fixation, but it is because of the primary injury. There is an injury to the physis that causes a genivolvum. So then all you need to do is you need to do a guided growth procedure and you can completely correct this genivolvum. Now let's look at this case. This is again a distal femur fracture. X-rays looks extremely innocuous. It is only when you get a CT or an MRI. So if you ask me with a CT or MRI, so in physeal injuries, I get both. There is no harm to get both of them done. But if you ask me one investigation, then I prefer an MRI over the CT because it gives me a lot of information regarding the articular cartilage as well as the hyaline cartilage which covers the distal femur. So it shows a complete fracture through the physis, and you can see the fracture line running from anterior to posterior. Or if you see the actual views here, there is a lot of information. One is that it is a complete fracture. Second, it tells you the fracture geometry. Third, it tells you whether the fracture is displaced or not. And fourth, and most important thing, it tells you about the direction in which you need to pass your screws. So if you look at this particular fracture, you need to pass your screws in a particular manner, especially when going laterally. You have to go lateral anterior to slight medial posterior so that you can get your lag effect across the fracture site. So this particular case, again, a type 3 Salter Harris injury, reduced completely and fixed with cannulate cancer screws only, went on to give a good result. Now, this is another case. This primarily wasn't my case to begin with, but this was a badly displaced distal femur fracture, badly displaced open injury. This was debrided primarily. This was debrided and fixed with 2 screws. The medial condyle was completely shattered. It was fixed with 2 screws. When this patient eventually came to me, this patient had multiple issues, including a significant amount of ligament discrepancy. So this boy came to me at the age of about 9 years, wherein we decided that we shall stop the growth on the opposite side. So we did a complete permanent epiphysiodesis on the left-hand side, and the right-hand side we deleted. The patient also had a significant stiffness, but we knew that at some point in time we have to lengthen this bone. So eventually, at the age of 12 years, we decided to lengthen it, and we got a good consolidate. The patient was on a fixator for almost about 9 months, but we got a good regenerate and some amount of RS. The joint is arthritic. The screws inside, it was not possible for us to retrieve them. There is some amount of stiffness which is there, but eventually this patient doesn't have a ligament discrepancy today. He is working. At some point in time, he probably will require some sort of an intervention for the arthritis. But as of today, this patient is working fine. In fact, he is an engineering student now, and he is an Instagrammer as well. And I follow him on Instagram. So you see a lot of his posts where he cycles, where he swims, where he goes for hikes. And it's quite a proud moment when you can get a patient from this condition almost in your models. Now, let's look at this particular injury. This is again a completely displaced type 4 Salter Harris fracture. Why do I say type 4? Because there is a fracture through the epiphysis, there is a fracture through the physis, and there is a fracture through the metaphysis. Now, these injuries are known to have a lot of issues as regards growth arrests, especially when they are in the periphery. You can have a growth arrest, which can lead to a deformity. So one thing which we are very, very certain about is that you need to get an anatomical fixation on these fractures. complete anatomical fixation as is shown here. And once you do that and you get the screws out, then you really need to follow these patients. Now, if you are aware of the anatomy of the ankle joint and especially of the distal tibial physis, the distal tibial physis is one of the last physis to fuse in children, and it usually fuses by the adolescent age, by the age of 16 years. So these particular patients, these ankle injuries, you actually need to follow them for a prolonged period of time, unlike other physial injuries where you say that after the age of 12 or 13 or 14, these will not kind of progress. So I have had cases where the physial injuries, we have had a severe deformity early, say by the age of 13 to 14. We've had to go inside and do an osteotomy and correct that deformity. If it is near the physis, correct the deformity. You cannot remove the physial bar remains. There is a recurrence of the deformity despite your best possible interventions. And eventually, you actually then do a re-osteotomy or a second procedure, get a final correction. So I've had cases where we need to do that. Now, looking at the bigger picture as regards MIS. Now, why do we talk of MIS? Is it only because we are concerned about the prosthesis? The answer to that is no. We are not only concerned about the prosthesis. There are multiple things which we are concerned about. One, prosthesis is a big part. Second and most important thing, restoration of function by anatomical reduction is an important part. Third, minimum trauma to soft tissues and structures surrounding the bone is a very important part. And fourth, which a lot of people may agree or not agree, but minimally invasive surgeries, children do not require hospitalizations for a long period of time. As there is no wound, you don't need to do a wound check, you don't need to put a drain, you don't need to be bothered about bleeding, you really don't need to be bothered about infections. So to summarize, if you look at the health economics, there it makes sense to actually do this. Like this particular patient had a distal fracture, and this was managed completely using a minimally invasive technique, and it has been to do very well. So to summarize my talk for today, MIS in pediatric orthopedic surgery is probably a boom with this generation. Because we are in an era of image-guided surgery, we are in an era of automated surgery, we are in an era where I started using a hand drill, and I'm sure Neeraj also started with that. We now have drills which are, even the residents are using automated systems. You have better implants, you have better fracture tables, you have faster recovery times, you have better casts. So what does MIS do? It reduces hospital stay and gives a faster recovery. It has one of the lowest risk of complications because you're not opening up the fracture site, provided it is done properly in trained hands. You don't require as many follow-ups and probably don't require surgeries because most of these wires can be pulled out on a weekly basis. There are smaller incisions or no incisions and hence less trauma. You require lesser staff, lesser resource allocation, and therein you not only save costs, but you also see to it that the patient goes home very, very fast and will not be in the hospital for a long period of time. Thank you very much for your attention and for this opportunity. I'll be very happy to take questions. Thank you.
Thank you, Swapnil. We'll stop your screen share now. So there are some questions from our viewers. The first question is related to your first case, is that when you have the fracture of the distal radius, and sometimes you do the minimally invasive technique, you put one wire, and sometimes you say that you put the second wire. Sometimes the fracture is so distal in the radius that it is actually very difficult to put the second wire without escaping the physis. So do you advise that we can put the wire through the physis, especially in a younger child like 7-8 years old, or shall we avoid the physis completely and just do one wire and casting?
Neeraj, just 1 minute. There is some issue with my screen. I'm trying to fix it. Something is happening. I actually cannot see it. Oh, I don't know what this is doing. So I can see some picture on the screen. I don't know. Can you see me completely?
Yes, I can see you very clearly. Just
Okay.
look in the camera, you can answer.
Yeah, sure. So I think you said that a distal radius fracture where you need to go through the physis is what you're saying.
Yes.
So you never do that. You never do that. If you really want to reduce it, you can actually go antegrade. You can go from proximal to distal. Try and still come out of the metaphysis, but it is my humble request and appeal to everyone to not go across the physis of the distal radius because it will cause growth arrest. Even if you are using a single attempt to reduce it, it will cause growth arrest. So try and avoid it as much as possible.
Okay. Now the second question is related to the femur tense nailing. So is there a age group where you would like to say it's like a short oblique fracture? It's a stable fracture where we can reduce it. And so what is the age group where you would like to do only tense nailing in a short oblique fracture?
Tense nailing vis-a-vis, are you asking for
Hey, from the child, say basically not a non-surgical, to a tense nailing to an interlock nail. So basically, what will be that middle age group where you will do only the tense nailing?
Correct. So if you look at the AAOS recommendations, okay, the recent recommendations of 2024, they now say that it is less than 5 years. And we have had some data which we presented in our journal club very recently, where they said that even in 4-year-old children, they have done nailing now. I think that is too much of an overkill. If you ask me in my personal clinical practice, then I tend to do elastic nailing in children who are over 5 years of age. But unless the child is extremely obese, the fracture is difficult to control. In a spica, usually 5 years is my cutoff. Anything below 5 years, I'll try and treat in a spica. Anything above, say, 5 years till about 12, 13 years, I would mostly do a nailing if it's stable. Anything over 13 to 14 years, a slightly heavier 14-year-old, I will then think about a trochanteric entry of female.
Got it. Okay, so now we come to the next part, which is the supracondylar and the lateral condyle. So in which situation will you open a supracondylar fracture? Say it is grade 3, non-vascular. And in which situation will you open a lateral condyle fracture? Again, non-vascular, no neurovascular problems.
Okay, so I'll come to the lateral condyle fracture first. Irreducible lateral condyle fracture where you cannot get anatomical reduction closed, especially a completely displaced fracture with the song type 6, where it is completely, the articular surface is facing the fracture side and the fracture is completely rotated, or the type 5, where it is a completely displaced fracture and you cannot get an anatomical alignment close. That is where I will do an open reduction to get the fracture into alignment. Now, coming to supracondylar fractures, as I said in my presentation, I do not try to open them, or rather, I would say that I try to keep them closed as much as possible. So now what I've started to do is that a completely displaced fracture where there is a complete overlap between the proximal and the distal fragment, that the distal fragment is posterior, the proximal fragment is anterior. Rather than trying to attempt a close reduction, I try and do the cantilever method primarily. So what I do is I place the patient in supine position on a fracture table. I turn the, I flex the elbow to 90 degrees. I then basically do kind of an internal rotation maneuver. I try to make a small incision at the fracture site. So I make a small incision. I dissect bluntly with the atraumatic artery forceps. I then try and deliver this artery into the proximal fragment across the distal fragment. So I actually go this way, then I try and get a hold of the proximal fragment, and then I try and push the distal fragment to the proximal. So what it does is it just aligns the distal and the proximal fragment, And once that happens, it is still rotationally unstable because you are in internal rotation. So when you get to neutral rotation, and once the fragments are kind of interdigitated, you get a near total anatomical reduction. Then all you need to do is give some amount of traction, some amount of varus valgus, and you are able to get an anatomical reduction, and then you can fix it with wires. So that is what I do. The only time when I have had to open, which is very rare, is when there is a pucker sign positive. That is, the fracture is closed, but the proximal spike has gone through the brachialis and it is lying in the soft tissue. A part of that spike is interdigitating into the skin on the medial side, causing some sort of a hematoma and a pucker. Now, these are the ones which you cannot get it closed. However, if you ask me in expert hands, there are maneuvers by which you can actually do a knee open surgery there. You can just release the soft tissue, the pucker, and try and lever this fragment inside. But that requires a different level of expertise. And you also need to be very, very certain of the anatomy around the elbow because you cannot be poking your hemostat here and there and injuring the neurovascular bundle. So for the uninitiated, I would say that if a pucker sign is positive, and if the spike of the proximal fragment has gone through the brachialis, is holding the skin, or has come out of the skin, or there is a hematoma there which tells you that there is subcutaneous injury, that is where you do an open reduction. You can do a medial approach, you can do a lateral approach. I would do a medial approach because usually the puckering is on the medial side. So I can actually open it up, open the brachialis, visualize the neurovascular bundle, see to that the neurovascular bundle is not coming in between the fragments, reduce it under vision, and then put wires to stabilize it. So that is my kind of threshold for opening up of fractures, displaced fractures, which are closed injuries.
Okay, so the next question is a little more basic, that in a supracondylar fracture, when you have put the K-wire, fracture is stable, you have not opened it, and there are no stitches. Would you like to put a slab or would you like to put a cast?
So it actually depends. Now, actually, if I do not have too much of swelling and I'm not really concerned about, say, a compartment syndrome sitting up in the night, I would put a slab. But what I do is that in 90% of these cases, I put a little bit of a loose plaster. So how do I do that? I actually put a lot of padding and apply a plaster, a fiber cast very lightly. I give good amount of limb elevation, wherein I keep a pillow below the elbow and then raise the arm this way. I keep asking the patient to move the fingers, and I ask the parent, especially if I'm not going to visit that same night, to tell me if there is any sort of a stretch pain or there is severe pain. I even instruct the residents who are in the ward that if there is any kind of pain, just call me or just slit the plaster, and if at all that. But luckily, it doesn't happen. So basically, I would say that a cast is a little more safer than a slab, and you can apply a loose cast. So this cast is not really holding your fracture. All it is doing is that it is just supporting the fracture, seeing to it that the child doesn't move. Because what happens is many times, put a slab, send the child home, and the child comes with a broken slab. And when the child comes with a broken slab and he's moving and God forbid your wires break, then you are in a big, big soup. If your wires come out and you lose reduction, then you are again in a big soup. Because at 7 days or 10 days, these are almost irreducible and they cannot be reduced. So but that's the thing that I really put them mostly in a cast or try to put them in a cast as much as possible.
Okay. So there is a proximal tibia fracture, which you showed, you put an external fixator.
Yeah.
So now there is a special type of fracture where whatever you do, it goes into valgus.
Yeah.
It is called something. What
Cosen's
is it
phenomenon.
called? Yeah, Cosen's phenomenon.
Cosen's
So
phenomenon.
yeah, so there is no way to avoid it, is what I have understood. That it will go in valgus whether you operate or whether you do close reduction or whether you put a plaster, whatever it happens. Does it happen like that, or if you put a, say, like a fixator in that and it does not go into valgus, is it like that?
No. So Cosen's phenomenon is actually a green stick fracture of the proximal tibia, right? So it is not really a displaced fracture, but somehow the forces acting across the fracture cause it to eventually heal but take the limb to valgus. It is also a fracture which is very, very close to the physeal. That could be one of the reasons. So these are treated close to try and give a varus force to them. But you always tell the parents whenever you get these fractures that you will have a Posit's phenomenon and these will go into valgus and you will require a magnet. So if you look at these fractures over a period of time, once you correct them with the help of an end plate, they remain straight. So it's not a complete fascial damage. It is essentially what happens is that when there is a fracture at the medial side, there is probably excessive amount of vascularity which comes in, which stimulates excessive growth on the medial side as compared to the lateral side, leading to the process. And eventually, I think this corrects very well if you just do a guided procedure, even.
So the next question is about the ankle fractures. So they
Yes.
are not so commonly seen in even in general orthopedic practice, at least maybe in pediatric practice also they may be a little common than us. So you showed that there sometimes you can correct it minimally invasive. But
Right.
what I had heard that basically usually these are the Tilo fractures and you should always get a CT scan done before you operate on these.
Yeah, I
What is your
completely
recommendation?
agree. So many of these are what we call as box fractures. Many of them are triplane injuries. Essentially, you have injuries in three planes. Now, the reason we get a CT done in most of these cases is because we need to see all the planes in which the fracture is occurring. The reason is that you sometimes need to actually fix the metaphysis and diaphysis, and the direction of the screws are in different planes. That is one thing. The second thing why we CT is because you get a three-dimensional idea about the rotation and also how you're going to manage your reduction in intraoperatively. So many a times, striking injuries or these flux fractures come closed, provided with the correct material, right? So you need to do a CT scan to get a complete three-dimensional picture as to where the metaphyseal fracture is, what is the direction of the fracture line, how and where is it crossing the physis, and then how it is going across the epiphysis. And then decide whether you're going to do a open reduction, whether you use reduction, whether you're going to put an anterior-posterior screw, whether you're going to put a mediolateral screw, or whether you're going to put a complete screw. So all these decisions can only be made on a CT scan. Now, they are not actually that uncommon. Usually, these triplane injuries happen in the age group of 16 to 17 years. And the reason for that, as I mentioned, is that the distal tibia is a very unique physis. It fuses the last. So it actually starts in the center. The fusion starts in the center of the distal tibia. Then it goes to the lateral side and then it goes to the medial side. Now, when this is happening, and then you get a kind of a torsional injury or a rotational injury, you get a very typical kind of a fracture, which is fractures in three planes, because the fracture line will always go through the path of least resistance, right? That is why you get a different fracture line in the epiphysis. The fracture line then goes across the physis, and you get a different direction fracture line across the metaphysis, right? And they are not that uncommon. Of course, we don't see them as commonly as a supracondylar or a lateral condyle, but they do come. And when they come, they are quite challenging because you have to deal with a lot of things. You need to deal with one, complete anatomical reduction, understanding all the three components of this fracture, reducing them perfectly, getting a good fixation, and see, you cannot use plates in them because you're going across the physis. And despite doing a very good job or a near anatomical job, eventually you can get a deformity for which you require a deformity correction. So every patient coming to me with this kind of an injury at this particular age group, I tell the parents that we will fix the fracture, we get a good reduction, but eventually, despite our best attempts, the primary injury causes a physeal damage, which will either lead to a varus or a valgus, or a deformity in the third plane, which will eventually require osteotomy after skeletal maturity or submarinal skeletal maturity.
Yeah, I think that's all from Ortho TV side. Thank you,
Right.
Swapnil. Yeah, we thank Swapnil for a comprehensive coverage of pediatric trauma, not only minimally invasive, but he covered a lot of topics from upper limb and lower limb both. We thank our viewers who have always been with us through the lockdown and now after the lockdown also. Hope this webinar reaches to all over the world. And we thank our supporters, Haleon, the makers of Centrum Joints and Mobility, for bringing us this webinar. Thank you very much and good night to all.
Thank you.
Thank you. Bye-bye. Poonam, stop.
Neeraj?